Hello all, myself Dr. Sufia Tasneem, Senior Lecturer from the Department of Orthodontics, Sri Siddhartha Dental College. Today I will be discussing the topic on oral habits. Oral habits are repeated and unconscious behavior involving the mouth, teeth and surrounding structures. It develops because of the comfort and stress relief. There are various oral habits such as thumb sucking, tongue thrusting, mouth breathing, bruxism and lip and nail biting. The oral habits, if it continues beyond 4 years of life, leads to the malocclusion. These are the contents under which I will be covering the topic. Coming to the definition of oral habits, various authors have defined oral habits as, according to the Dorland in the year 1957, a fixed or a constant practice established by frequent repetition. According to Butterworth, in the year 1961, a frequent or constant practice or acquired tendency which is fixed by frequent repetitions. According to the Finn, in the year 1972, oral habit defined as an act that is socially unacceptable. According to the Moyer, in the year 1958, a learned pattern of muscle contraction which is complex in nature. Coming to the classification of oral habits, various authors have classified it as, according to the James William in the year 1923, it is classified as useful habit and harmful habit. According to the Klein in the year 1921, it is empty habit and meaningful habit. According to the Morris and Bohanna in the year 1969, it is pressure habit, non-pressure habit and biting habit. According to the Finn, it is compulsive habit and non-compulsive habit. According to the Kingsley, it is functional habit, muscular habit, combined habit and then postural habit. Coming to the thumb sucking. Thumb sucking is defined by Gallin in the year 1978 as placement of thumb into various depth of the mouth. According to the Moyer in the year 1988, repeated and forceful sucking associated with buccal and lip contraction. Sucking habits is classified by Brain in the year 1996 as nutritive sucking and non-nutritive sucking. Nutritive sucking example is breastfeeding and bottle feeding. Non-nutritive sucking is pacifier sucking and digit sucking. Subtly classified thumb sucking based on the amount of progression of the thumb into the mouth. There are 4 types in the type A, type B, type C and type D. In the type A, the entire thumb is inserted into the oral cavity where the pad of the thumb inserts the pressure on the palatal mucosa and palatal surface of the upper incisors. Here both upper and lower incisors are in contact with the thumb. Coming to the type B, thumb is inserted into the oral cavity not beyond the first joint. Here only upper incisors are in contact with the thumb and thumb exerts pressure on the palatal surface of the upper incisor. Coming to the type C, here thumb is inserted into the oral cavity as in type A, but only upper incisors are in contact with the thumb but lowers are not in contact with the thumb. Coming to type B, here only little portion of the thumb is inserted into the mouth. Upper incisors are not in contact with the thumb, only the nail bed of the thumb is in contact with the lower incisors. Coming to the phases of development of thumb sucking, phase 1, phase 2 and phase 3. In phase 1, it is considered to be normal and subclinically significant. It is seen in the first 3 years of life. Coming to phase 2, it is clinically significant phase which is seen in the 3 to 6.5 years of life. It happens because of the greater anxiety in the child, and then here treatment of the dental problems can be initiated in the phase 2. In the phase 3, it is irretractable sucking. It persists beyond 4 to 5 years of life. It happens because of the psychological problems. Coming to the Cook's classification, he classified thumb sucking into 3 patterns, that is alpha group, beta group and gamma group. In the alpha group, there is thumb pushes the palate in the vertical direction, little buccal wall contraction is there. Coming to the beta group, here strong buccal contraction with negative pressure shows posterior crossbite. Coming to the gamma group, here alternative positive and negative pressure is seen with least effect on the anterior occlusion. Coming to the etiology of thumb sucking, various authors have put forth various theories to explain the etiology of thumb sucking. Freudian theory given by Sigmund Freud in the year 1905. According to this theory, child passes through the various phases of psychological development. In that, oral and anal phase are seen in the first 3 years of life. Oral phase, mouth is considered to be oroerectic zone. The child has a tendency to keep any object or digit into the mouth. Prevention of this results in the emotional insecurity. Next, Oral drive theory given by Sears and Weiss in the year 1950. Prolonged nursing leads to the thumb sucking habit. Next, Benjamin's theory given by Benjamin in the year 1962. According to this theory, thumb sucking arises from the deep-rooted reflex seen in all mammalian infants. Rooting reflex is the movement of the head and the tongue towards the object which touches the cheek, and this rooting reflex appears by 7 to 8 months of age. Coming to the psychological aspects, children deprived of parental care, love and affection will develop feeling of insecurity. Coming to the learned patterns, according to this theory, habit doesn't have any underlying cause or psychological barrier. It is learned by itself. And then coming to the effects of thumb sucking. The severity and effects of thumb sucking is based on these three factors, that is duration, frequency and intensity. Duration is how long the child is indulged in the habit. Frequency is how many number of times habit was actively performed. Intensity is how vigorously the habit is performed. Coming to the pathophysiology of thumb sucking, child places the thumb into the mouth. There is a negative pressure created within the mouth, tongue position lower, and then pressure against the upper anteriors, and then cheek pressure against the upper posteriors, leading to the increased activity of the buccinator mechanism and absence of opposing tongue muscle force, leading to the narrower upper arch and high palatal vault. Next, extraoral features of thumb sucking. Coming to the thumb, there is cleaned, dampened shaped thumb is present with callus formation in the sucking side of the thumb. And then facial profile and skeletal changes. There is convex facial profile is seen with prognathic maxilla and retrognathic mandible. And coming to the lip posture, there is hypotonic upper lip and hypertonic lower lip. There is increased mentalis muscle activity is seen, incompetent lips, and then increased interlabial gap is present. Coming to the intraoral examination, effects on the maxilla, there is proclination of the maxillary incisors, and then increase in the maxillary arch length is seen, and then increase in the anterior placement of the apical bone, and increase in the SNA, and then increase in the counterclockwise rotation of the maxilla. Coming to the mandible, there is retroclination of the mandibular incisors, and there is increase in the mandibular intermolar distance. Coming to the interarch relationship, there is increased overjet and anterior open bite. There is posterior cross bite and unilateral or bilateral class 2 malocclusion is seen. Coming to the effects on the tongue, tongue is low position and there is increase in the tongue thrusting habit. Because of that, there is anterior open bite. Because of the tongue which is lower position, there is constriction of the maxillary arch leading to the posterior cross bite. And other effects, there is high incidence of middle ear infection, and then there is increased risk of speech defects. Coming to the diagnosis, diagnosis can be done by taking history, emotional status of the patient has to be checked, and then extraoral examination and intraoral examination. Coming to the management, psychological approach, reminder therapy and corrective therapy. Under psychological approach, it is done when the child is beyond 8 years of age. Here there is a Denloup's beta hypothesis is done, where the child is advised to sit in front of the large mirror and perform the habit by seeing into the mirror. Because of the conscious purposeful repetition, the habit drops. Coming to the reminder therapy, it is done in the age of 6 to 7 years of age, where child wants to quit the habit but not able to quit it. There we can give the restrictive approach can be given, and then chemical approach. In restrictive approach, bandaging the thumb and thermoplastic thumb guards can be given. In the chemical approach, pepper dissolved in the volatile medium and quinine aspartate can be given. These are the bitter components which is applied to the thumb, where the habit becomes a pleasure habit. Coming to the intraoral appliances, there are removable habit breaking appliances and fixed habit breaking appliances, such as vertical and flat crib appliances, and then bluegrass appliances and rake appliances. And then coming to the corrective therapy, this has to be started when the child is in late mixed dentition to permanent dentition stage beyond 8 years of age. And then here we can give the expansion appliances such as quad helix. Coming to the tongue thrusting habit. Tongue thrusting habit is forward placement of the tongue between the anterior teeth against the lower lip during swallowing. Coming to the classification of tongue thrusting, there are 4 types, that is type 1 deforming tongue thrusting, type 2 deforming anterior tongue thrusting, type 3 deforming lateral tongue thrusting, type 4 is deforming anterior and lateral tongue thrusting. Moyers has classified tongue thrusting into simple tongue thrusting, complex tongue thrusting and retained infantile swallow. In the simple tongue thrusting, teeth are in occlusion. In the complex tongue thrusting, it is teeth apart swallow. In the simple tongue thrusting, anterior open bite is there. In the complex tongue thrusting, it is more diffuse open bite. In the simple tongue thrusting, it is a history of thumb sucking habit, but in the complex, there is history of chronic respiratory illness is there. And in the simple tongue thrusting, it has good prognosis, and complex tongue thrusting has poor prognosis. In the simple tongue thrusting, there is a contraction of the lip muscles, mentalis muscles and mandibular elevator muscles. And in the complex tongue thrusting, there is contraction of the lip muscles, facial muscles and mentalis muscles. Coming to the retained infantile swallow, the transition of the infantile swallow to the mature swallow should happen after the eruption of the posterior teeth. Whenever there is a delay in the transition, leads to the retained infantile swallow. Here there is open bite which extends up to the buccal segment, and then only molars are in occlusion in both the sides. Coming to the etiology of thumb sucking, given by Fletcher in the year 1975. Genetic factors, here neuromuscular variation is there. Because of that, there is hypertonicity of the orbicularis oris muscles leads to the tongue thrusting habit. In the maturational, the infantile swallow has to convert into the mature swallow after the eruption of the posterior teeth. Whenever there is a delay in the maturation, leads to the tongue thrusting habit. Mechanical restrictions such as macroglossia and enlarged adenoids can lead to the tongue thrusting habit. Learned behavior, if there is a prolonged thumb sucking habit and abnormal bottle feeding, can lead to the tongue thrusting habit. And then neurological disturbances such as hyposensitivity of the palate and then moderate muscular disability can lead to the tongue thrusting habit. And then in the psychological factors, whenever there is a forceful cessation of one habit, leads to the development of the other habit. Coming to the extraoral features of tongue thrusting, lip posture increase in the interlabial gap is present, and then mandible and the tongue, there is no coordination in the movement of mandible and the tongue. And then coming to the speech, there is lisping. Coming to the intraoral features, here there is proclination of the upper incisors, spacing in the upper and lower arches, and then anterior open bite, posterior open bite because of the low tongue thrusting habit. And then because of the low positioning of the habit, there is constricted upper arch leading to the posterior crossbite, and then there is retained infantile swallow is present, and then incompetent lips are present. Coming to the management of tongue thrusting, child below 3 years of age doesn't require any treatment, and then tongue exercises and the lip exercises can be performed, and then reminder therapy can be given and corrective therapy. Under the tongue exercises, we can advise these are the tongue exercises such as correct tongue tip positioning, and then Andrews practice and use of sugarless mint, single elastic swallow by Gardner and double elastic swallow can be performed to reduce the tongue thrusting habit. And then lip exercises such as lip pull exercise and lip over lip exercises are performed to strengthen the lips and to reduce the tongue thrusting habit. Coming to the intraoral appliances, the vertical flat crib appliances can be given, and then bluegrass appliances can be given, and rake appliances. Coming to the corrective therapy, in this the posterior crossbite which has happened because of the constricted maxillary arch can be treated by giving quad helix appliances. Coming to the mouth breathing, according to the Sessone in the year 1971, he defined mouth breathing as habitual respiration through the mouth instead of nose. Coming to the pathophysiology of mouth breathing, the mouth breathers has the 3 postural changes which occur in the mouth breathers, such as there is backward tilt of the head and the lowering of the mandible, and then downward and backward. Pathophysiology of mouth breathing, the mouth breathers has 3 postural changes such as head tilted backwards and the lowering of the mandible, and tongue which is positioned downward and forward. And then these postural changes leads to these effects such as increase in the anterior facial height because of the supraeruption of the posterior teeth, and then vertical growth of the ramus leading to the clockwise rotation of the mandible, and then anterior open bite because of the clockwise rotation of the mandible and supra-eruption of the posterior teeth, and then there is increased overjet and increased mandibular plane angle and narrow maxillary arches are seen. Coming to the classification of mouth breathing, it is based on the etiology such as obstructive, habitual and anatomical. In the obstructive, there is obstruction in the nasal passage such as deviated nasal septum and then any enlarged adenoids which are present in the nasal septum and any inflammatory reactions in the nasal mucosa. Coming to the habitual, even after the cessation of the obstruction, habit still persists. And then coming to the anatomical, there is short upper lip present in this. Malocclusion with mouth breathing habit leads to the long face syndrome, such as there is increase in the lower anterior facial height is seen in the mouth breathers, and there is long and narrow face is present and the narrow nose and nostrils, and then there is incompetent upper lip is present and then backward rotation of the mandible is seen. Coming to the intraoral end, there is increase in the mandibular plane angle. Coming to the intraoral, there is anterior open bite and then posterior cross bite because of the narrowing of the maxillary arch because of the low position of the tongue. And then there is increase in the overjet and there is anterior marginal gingivitis is there, and then because of the dryness of the mouth, there is high tendency for the caries to develop in the mouth breathers. Coming to the diagnosis of mouth breathing, history has to be taken, and in the examination there are certain tests which has to be performed such as mirror test, butterfly test, water holding test, cephalometrics and rhinomanometry. In the mirror test, there is double-sided mirror which is placed in between the mouth and the nose, and whichever side there is a fogging. If there is a fogging towards the nasal side, patient is a nasal breather. If there is fogging towards the mouth side, patient is a mouth breather. Coming to the butterfly test, the butterfly shaped cotton is placed between the nose and the mouth. The fluttering of the cotton suggests the whether the patient is mouth breather or nasal breather. And then coming to the water holding test, patient is advised to hold the water for 2 to 3 minutes. If he is a mouth breather, he will be unable to hold the water. And then coming to the cephalometrics, we have to determine the amount of nasopharyngeal passage can be seen by cephalometrics, and then size of the adenoids can be checked by using lateral cephalograms. And coming to the rhinomanometry, here the airflow in the nasal passage and nasal resistance can be calculated. Coming to the management of mouth breathing, first is elimination of the cause, next is interruption of the habit by exercises and mechanotherapy, and next is correction of malocclusion. These are the lip and muscle strengthening exercises. Coming to the bruxism. Bruxism usually refers to the nocturnal subconscious activity but can occur during day or night, may be performed consciously or subconsciously. Coming to the etiology of bruxism, local occlusal interferences, pericoronitis and periodontitis, and then systemic causes are gastrointestinal, endocrinal, neurological disturbances, and then nutritional and vitamin deficiencies can cause bruxism. Psychological problems such as emotional stress can cause bruxism, and occupational athletes. Coming to the clinical features of bruxism, there is occlusal wear facet. Because of that, there is hypersensitivity of the dentine is seen, and then fracture restorations and the teeth can be seen, and then tenderness and hypertrophy of the muscles of mastication, and the pain in TMJ can be noticed. Coming to the management of bruxism, this first we have to treat the underlying cause, and then psychotherapy can be done, and drugs can be advised, and then occlusal splints can be given, and we have to restore the vertical dimension of the patient, and then electrogalvanic stimulations can be done, and ultrasonic can be done, and aquapuncture and TENS, that is transcutaneous electrical nerve stimulation, can be done to treat the bruxism. Next is lip biting. Lip biting often involves lower lip that turns inwards and pressure is exerted on the lingual surface of the maxillary incisors. Etiology of this is also anxiety, and there is nervous behavior. Coming to the clinical features of lip biting, there is increase in the overjet and lip trap is present, and then hyperactive mentalis muscles and the lower lip injuries can be seen. Coming to the nail biting habit, placement of one or more finger into the mouth and biting the nail. Incidence in 3 to 4 years it starts. In the from childhood to adolescence, there is incidence rises sharply, and in the adulthood it decreases. Coming to the etiology, there is emotional tension and genetic and environmental factors are involved, and psychiatric disorders are involved in nail biting habit. Coming to the clinical features of nail biting, there is gingival inflammation and infection, and there is apical root resorption can be seen in the nail biting patients, and then there is crowding and rotations can be seen. Chopped nails can be seen in the nail biting patients. Coming to the management of nail and lip biting, there is non-pharmacological approach such as psychological counseling and hands activity can be done. In pharmacological approach, we can advise a patient selective serotonin reuptake inhibitors and tricyclic antidepressants can be advised in pharmacological approach. And then lip bumpers can be given and oral screen can be given to treat the nail and lip biting habit. These are the references. Thank you.